Good to meet everyone today. I'm really happy to see so many people show up for this workshop. We're excited to share some epi information with you and talk about COVID and what's been going on for the last couple of years. So if we can go on to the next slide, then we're going to start with some introductions. And Xana, if you want to just start us out on that, then I can kind of take us into the next couple slides.
Yeah, hi everybody. Lovely to be here with everyone this afternoon. I'm Xana Berg, and I currently work for an organization called the Montana Budget and Policy Center, and I'm the director of Kids Count. My background is in epidemiology. I have an MPH from the Colorado School of Public Health, and I worked as an epidemiologist for the WIC program in Colorado for a couple of years before moving to Montana.
All right, and so I'm Ethan Walker. I am currently assistant professor in the School of Public and Community Health Sciences at the University of Montana. So my research focuses on air pollution, and mostly from wildfires and wood stoves, which are two very relevant and prevalent air pollution sources in the Western Montana area. I have also been involved some with the Missoula City County Epidemiology Situation Unit throughout the COVID pandemic and gotten a little bit more involved in infectious disease and COVID related research with the county here and also the state of Montana. I'll talk a little bit about some of the work we've done. Previously, I started out in healthcare as a registered nurse. I worked for a few years as an RN and then went to grad school, got an MPH in epidemiology, and then stayed in grad school because I liked that for some reason, and did a PhD in environmental health and epidemiology at Colorado State. And if you notice that Xana and I both went to the Colorado School of Public Health, that's actually where we met, and we're actually married. So just a little fun fact to get us started for the day. With that, we're going to go on to the next slide. And if you would like to participate in the chat and just shout out where you're from, kind of what organization you work for, what your role is. And, I think we asked in a question during the enrollment process, if you have any kind of specific questions. So we do welcome questions throughout this. We'll have some time set aside kind of at the end of each day to really dedicate towards questions and trying to answer your questions as best as we can. But yeah, we do welcome you just to use the chat function and please reach out to us. And on the next slide, then we'll kind of go over the agenda real quickly. So today we're going to focus really on some basics in epidemiology, just an introduction on terminology and different data sources, data calculations, and study designs. So
did he freeze for anyone else?
Yes,
yeah, okay.
He froze for me too.
Oh no, Ethan, come back to us. Oh,
can you hear me right?
You froze on us, so you might go back a few sentences.
Oh no, sorry, I'm on campus just for the good internet connection and it's freezing up on me. Can you hear me okay now?
Yep, you're
Great.
good.
All right. We know that some of you might have different experience in epidemiology. So our goal here is to not get too in depth on any one concept, but we're really doing a crash course here, basics of epidemiology. And if you already know this, hopefully we can reinforce some concepts and give you some tools and resources to learn more. Tomorrow, we're going to focus really on COVID. So we're going to take some of the concepts we learned today, apply those to COVID, what we've learned the last couple of years, how to minimize and assess risk in the context of this ongoing pandemic. So hopefully this is helpful to you. Please do, as I said, reach out with questions. And we look forward to the next couple of afternoons and spending that time with you. And that, I think Xana's going to start us out here.
Awesome. So yeah, I'm going to get us started. We're going to spend about the next half hour talking about some vocabulary and basic concepts in epidemiology. We're going to be throwing around these terms a lot for the rest of today and then tomorrow. So just want to build a solid foundation so that we understand some of these terms that we're using. Perhaps a great place to start is to talk about what epidemiology is, since that's what the whole focus is. So epidemiology, it's the study of disease and how disease is distributed in populations, and then the factors that influence that disease. I like to think about epidemiology as the science of public health. And so when we think about diseases, there are many different types of diseases, both chronic diseases, infectious diseases. Our work as an epidemiologist looks different depending on what type of disease we're talking about. COVID is a great example. When we think about the early stages of COVID-19, we didn't know what was causing this respiratory disease. And so in that case, an epidemiologist acted more like a detective, trying to figure out what was the source of this new emerging disease. Other epidemiologists study diseases that we know quite a bit about, thinking about things like asthma or obesity. For an epidemiologist that's kind of playing that role as a detective, three things to really think about kind of initially as you're trying to understand a disease is person, place, and time. And so really trying to find a common denominator between what are the people who have a disease, what do they have in common? So in terms of the people who's impacted, what's that common denominator? Is there a place that they all have in common? Where do they live? Where have they been? And then in terms of time, when did they get sick? How long after a potential exposure? So really thinking about kind of these three: person, place, and time when we're trying to discover, what might be causing an unknown sickness. So for epidemiology, we're going to talk a lot about numbers over the next 2 days. And so we want to have some common terms to use for four pretty frequent measures that we'll use to describe disease occurrence. And so these four that we're going to run through are counts, proportions, ratios, and rates. And so you're going to get a copy of all of these slides. And so these links that we have in here, kind of hinting at good resources, you'll have access to all of those. Instead of going through them all at once, I want to go one by one and look through examples just to get a really good foundation of what these terms mean. So we'll start with count data, and count data is the simplest. It's just the counting up the number of cases or events. It's the simplest way to present disease, and we have an example here at the bottom. It's looking at the total cases of COVID-19 by age group. And so if we take a minute to look at what this data is showing, we can see as the longer the bar, the more number of cases there are. So this bar here that's got the highest number belongs to the 20 to 29-year-olds. So we're seeing that since the beginning of the pandemic, the largest number of cases has occurred in the 20 to 29-year-olds. One other thing maybe to point out here is that the lowest age group is the 80-plus-year-olds. And so one thing with count data, while it's the simplest, it does have limitations. So it lacks a lot of additional context. And so if we want to answer the question, well, why are the 80-plus-year-olds the lowest group? Is it because there's just fewer people in that age category? Or does it have to do with, maybe it's less common or less infectious in that age group? We don't have a lot of those answers just looking at this count data. So it does have its limitations, and some of these other measures we're going to talk about kind of overcome those limitations. But number one, just looking at the counts is one way to measure disease. Now, the other three we're going to run through all have to do with fractions. So just a quick note on fractions. When we talk about this, there's a number at the top called the numerator, and we're dividing that by a denominator. We're going to talk quite a bit about whether or not the numerator is included in the denominator. And so just wanted to run through a reminder of what we're talking about when we talk about numerators and denominators here. So counts is one way to measure disease. The second one we're going to talk about is proportions. And so for a proportion, we're talking about the fraction of a population with a case or an event. And for proportions, the numerator is included in the denominator. Proportions are often expressed as a fraction, a percent, or a decimal. So one example here is to look at some data in Montana. So since the beginning of the pandemic, 3,105 cases of COVID-19 have resulted in death. If we divide that by the total number of cases, we see that 1.2% of total cases in Montana have died. So that 1.2% is a proportion. And the reason why it's a proportion is that the cases that we count as deceased in the numerator are also counted in the denominator. So that's what distinguishes it as a proportion. Another type of measure that we can talk about with fractions is a ratio. So a ratio compares two events that have occurred but in this case, the numerator and the denominator are distinct. So the numerator is not included in the denominator. Similar data from before, top number 3,105 cases resulted in death. This time in the denominator, instead of total cases, we're just looking at recovered cases. And so the numerator and the denominator here are distinct, and that ratio would be 1 case has died for every 100 who have recovered. Another common example of ratios outside of kind of COVID data is like student to teacher ratio or student to school counselor ratio. Again, those two numbers are distinct. So the last measure we're going to talk about are rates, and we'll just preface it by saying that rates are confusing. So rates also deal with fractions, and it's the measure of the frequency that an event occurs over a specific period of time. So it answers the question, how fast is the event occurring? And our denominator has a component of time to it. Now, the reason why it's so confusing is that rates and proportions are often used interchangeably or are confused with one another. So sometimes we'll hear that something is a rate, even though it's really truly a proportion, because it's lacking that measure of time. So a couple of examples of using rates. Some epidemiologists restrict the term rate just to those measures that have time in the denominator. So for example, an incidence rate would be 70 new cases of breast cancer per 1,000 women per year. So that has a time component in the denominator of per year. Some people will use the term more loosely, so referring to proportions that just have the population in the denominator. So one example you might hear when thinking about kind of an outbreak is an attack rate. So 20 out of 130 persons developed diarrhea after attending a picnic. So there's no time in the denominator, but some people will still refer to this as an attack rate. The main takeaways here, rates and proportions are often used incorrectly. For both, the numerator is included in the denominator. For it to be technically a rate, there should be time associated with the denominator. Sometimes that time is defined and it's, per person per year, but sometimes it's implied. Important part here is to know that there are differences and to know different ways to interpret rates and proportions in various scenarios. So just a resource here to kind of summarize the fraction pieces that we've talked about. So if you want to know whether something's a rate, a proportion, or a ratio, we need to look and see, is the numerator included in the denominator? If the answer is no, that would be a ratio. If the numerator is included in the denominator, we then have to look for that, whether or not time is included. Again, rates truly have a time associated with the denominator, proportions do not. So those are 4 measures of disease occurrence that we're going to keep building upon and talking about: counts, rates, proportions, and ratios. Layering on top of that, we want to cover 2 more terms that will come up frequently in epidemiology, and those are incidence and prevalence. So prevalence is the existing cases of a disease at a particular point in time or over a period of time, where incidence are the new cases of disease among a population. And so there's a visual here to help kind of think through what prevalence and incidence are measuring, and it's the epidemiologist bathtub, super exciting bathtub analogy. So we've got the bathtub and it's got water in it, and that water level is our prevalence. So that's the existing cases at a given point in time or over a period of time. So that's our water level. The water coming out of our faucet are our new cases. So that's the incidence. Those new cases eventually get added to the water level. Now, if water never left the bathtub, or it would eventually spill over, but with most diseases, there is a drain in our bathtub, either through mortality, deaths, or through recovery. So just to run through these 2 terms again, prevalence, those are the existing cases of a disease, can be at a given snapshot or a point in time or over a period of time. Prevalence helps us understand the burden of disease in a population, to understand what the extent of the public health problem might be. Prevalence is often expressed as a percentage. So here's an example of the the current smokers in Montana at 19%. So we took the total number of smokers divided by the population. We've talked about point prevalence. So that's taking kind of a snapshot in time to look at what the water level is, the current level of disease at one given time versus a period prevalence would be over a period of time. Point prevalence is much more common, and we're going to see some examples of that with COVID data here shortly. So that's prevalence. Again, incidence are new cases of a disease. It's often expressed as a rate, and it's often standardized or adjusted. And so we'll come back to that point in just a second. This visual here is kind of showing how prevalence and incidence kind of change over time. So if we look at figure A, we can see that this is a beaker and not a bathtub, but we've got our water level showing our baseline prevalence. Now, this is in figure A, it's a closed system, so there's nothing coming in or going out. But in the real world, what we're really looking at is picture D. So we have both incidence, new cases coming in, while we have cases going out. And so then our prevalence really depends on when we take that snapshot in time, since the water level is always changing. So we mentioned here that incidence is often standardized or adjusted. And so to kind of dig in a little bit to what that means and why it's important to standardize. So we're going to revisit the same chart that we looked at for our count data. So up here on the top, it's just the number of cases broken down by age group. And remember, we pointed out that the 20 to 29-year-olds had the highest number of cases, where the 80-plus-year-olds had the lowest. So we're going to now look at a standardized version of this data where we've accounted for what the population is in each of these age groups. So we've taken the total number of cases and divided it by the population. And we can see that the bars do change. We can see that the 80-year-olds, which were the lowest, now are no longer the lowest. We've accounted for the fact that the population of 80-plus-year-olds is lower relative to some of these other age groups. So standardizing data makes it so that we can compare it across different groups that may have different underlying population. In this example, we were standardizing so we can compare against different age groups. Another reason why we might standardize is to look across different geographies. And so here's a map from one of the COVID-19 sources we're going to go into later. It's looking at the case rate per 100,000. So we know that the population in Missoula is different than the population in Glacier County. And so it wouldn't be fair to just simply count up the number of cases and compare between the two, because we don't know what the difference in the underlying population is. So instead, standardizing and looking at the rate per 100,000 says, well, what would the COVID cases be like if all counties in Montana had 100,000 people? And so that's what this map is showing, is the rate per 100,000. And we're then able to compare these counties of different population sizes to each other. The darker they are, the higher their case rate is. So a few more thoughts about incidence and prevalence. So prevalence, again, that's our current burden of disease, our water level. It depends on the duration of the disease. So for things like COVID-19, the flu, or a cold, when you recover quickly or die quickly, your prevalence may be lower relative to your incidence, because the water is leaving the bathtub at a pretty quick rate. Versus if you have the disease for a longer period of time without recovering or dying, your prevalence or your water level would be higher. So these are things like obesity or asthma, diseases that people live with for many years and remain in the bathtub before leaving for one reason or another. So let's walk through a few examples using some of this terminology. This first example here is looking at asthma in 2010, and 9.1% of adults in Montana had asthma. And so we want to think about what type of number or frequency measure is the 9.1%. So you can go ahead and drop your answer in the chat. Is that 9.1% prevalence or incidence? This is really good to practice. So thinking about the 9.1% of adults in Montana, I'm going to ask the question in a little bit different way in case it's helpful. So 9.1% of adults in Montana had asthma in 2010. This isn't telling us how many newly diagnosed cases of asthma there were, just how many currently existed in 2010. So in this case, this would be the prevalence. So it's telling us the current burden of asthma for the snapshot in time for the whole year of 2010. So the incidence for asthma would look like the number of newly diagnosed cases of asthma in adults in 2010 would be the incidence here. So using the same 9.1%, is this a count, a proportion, a rate, or a ratio? So I'm going to talk through kind of some reasoning for why it might be one measure over the other. So if we're looking at 9.1%, first question I want to ask myself is, in order to calculate 9.1%, did I have to use a fraction? Is there some sort of denominator population that we took into account? And in this case, we did have to use a fraction to get that 9.1%. So we're not looking at how many total people have asthma. That would be a number like 10,000. We had to divide that number by something else in order to get a percent. So we know it's going to be a ratio, a rate, or a proportion. So then my question is the numerator included in the denominator? So in this case, in order to calculate that 9.1%, we were looking at the total number of people who had asthma, the total number of adults who had asthma divided by the total number of adults in Montana. So in that case, the numerator is included in the denominator. So now we've narrowed it down to a proportion or a rate. And in this case, it's a proportion because we don't have any time associated with it. So again, this is where there's some gray area with proportion and rate. We could maybe think about whether or not there was a time implied with this number, but just looking at a percent of people in a population, we're looking at proportion here. So a few more kind of practice examples here. So on February 18th, 2022 in Montana, there were 261,722 total cases of COVID-19. That had been reported since the beginning of the pandemic. 894 of those cases were newly reported that day. 3,690 cases were active at that time. So if we take the 894 new cases divided by the total number of cases, we find that 0.3% of total cases were newly reported on February 18th. So my first question, you can put it in the chat again, is what type of frequency measure is 0.3%? Is that a proportion or a rate? Okay, so thinking through kind of the reasoning behind this one. So if we're looking at 0.3%, we have to ask ourselves, is there a measure of time that goes along with this? There's not a measure of time, so this would fit more in the proportion category. So it's just simply looking at what percentage of cases were newly reported on a single day. And we're going to go through some examples in a little bit that do show rates for some of these same types of measures, which might be helpful to kind of distinguish the two from each other. So next question, what type of statistic is 894 new cases? Is that incidence or prevalence? Awesome. A lot of agreement in the chat that this is incidence, and that is correct. So new cases on a given day, that's the water coming out of the faucet, are new cases. Awesome. Okay, so last question. What type of statistic is 3,690 active cases? Is that incidence or prevalence? Also a lot of agreement that this one is prevalence, and that's true. Yes, this is the water level. How many active cases were there at that given time? Okay, so we're feeling pretty good about the incidence and prevalence. We are going to go through a lot more examples, specifically using COVID data that looks at kind of rates and proportions to kind of wrap our heads around that. Honestly, this type of stuff just takes practice. You know, thinking about the data, looking at different examples to really kind of to understand the difference between some of them. So with that, I'm going to pass it back over to Ethan to talk about a few more topics here.
Great, thanks, Anna. All right, so before Xana's gonna, like she said, walk through some more examples of using data and doing calculations using this COVID specific data. So before we get there, I just want to talk through a couple of other examples, kind of important concepts in COVID related epidemiology. So the first thing is epidemic curves here. So I want to walk through, you know, what this really looks like. What is an epidemic curve? This is really, it's an important tool in tracking the progression of disease over time. And we've probably all become quite familiar with these resources of epi curves or epi profiles, you might hear them called. We've probably seen tons of these over the course of the pandemic, and it's just a way to kind of visualize and track cases. So on the horizontal or x-axis, we have date of disease onset, which can vary whether, depending on what data availability you have. It could be date of symptom onset or date of test result. But each day is represented on the x-axis, and then on the vertical or y-axis we have just the number of cases of disease on each day. So it really gives a great representation of the progression of disease. You can track like peaks and drops in cases and really see where we're doing as a state, where we are as a state, as a county. So this is a recent epi curve from the state of Montana, and you can just see the peaks and the progression of the different COVID outbreaks and the different variants that have occurred over the course of the pandemic. So these are really helpful tools, but we do want to make one good point here, that they're only as good as the data used to make them. So if we can't consistently identify cases of disease, if cases are underreported, if there are severe delays in reporting cases, then the utility can really drop, especially, it's pretty easy to go back and fill in an epi curve like this historically once you've collected all the data. But in real time, like on that right edge, it can be difficult, especially when there's an outbreak and we're struggling to keep up with testing and that kind of thing. It can be difficult to really keep up and keep an accurate epi curve and know what the current status is. So keep some of these limitations in mind as you kind of work through and interpret epi curves like this. And then on the next slide, I also want to mention reproduction numbers. So reproduction numbers have been an important kind of concept throughout the pandemic, and these are as defined an R number or R value, a reproduction number. This is the average number of secondary cases of a disease caused by a single infected individual. So it's pretty easy to read and pretty easy to interpret. If R, it's either going to be a positive number or 0. So if R is greater than 1, that means the virus, that COVID is spreading, and it's spreading more quickly the higher the number is above 1. If R is less than 1, the spread is slowing. And then if we hit 0, it's stopped. So it's fairly easy to interpret. It's kind of goes hand in hand with those epi curves. Just a quick glance can kind of tell you where we're at in the progression and the transmission of disease. So on the next slide, then, the difficult thing about using R numbers is that they can be harder to calculate. Epi curves are pretty easy to put together, But with our numbers, you need two key pieces of information. So first, you need the daily cases or incidents of COVID, which is relatively easy to get. But where we struggle to get further than this is the serial interval is the second key piece of information. So the serial interval it's the time between the symptom onset of one case, a primary case, and then the symptom onset of secondary linked cases. So in other words, when did a person with COVID become symptomatic? And then when did someone that they gave COVID to become symptomatic? So the key here is that the cases have to be linked, because you need to know the time it takes the disease to spread from one person to another. And this is difficult information to find because you had to have key information on when people became symptomatic, and it's not that easy to acquire for linked cases at a population level. So our numbers are often calculated using a serial interval from different populations when this data is available. So luckily, early on in the pandemic, our group here at UM worked with Montana DPHHS and to acquire some Montana specific COVID data and calculate a Montana specific serial interval. So we've been able to calculate and report from this information Montana specific R numbers during COVID. And I can show you a resource where you can find those and look those up shortly here. And last thought here is that there are two different types of R numbers you might run across. The first is called R naught, and this is the value that you see at the beginning of the pandemic, early on in an outbreak, when you don't have very much information on how quickly a disease spreads, and prior to intervention. So it's really just telling us how fast does this move through the population. And then RT, or effective R, this is a different type of R value that's calculated for specific time frames. So this is what we're calculating right now. And you can look over different time windows and the current time frame, like over the past month, how fast is COVID spreading through the population. So it gives you kind of a snapshot in time of how we're doing that can really be complementary to like the epi curve and make some really great resources. So I'm gonna take over the screen here for a second and just walk through a couple of resources with you, some web pages. So we will give you these slides, and let me just pop my screen up here. Yeah, so we will give you these slides, and you can have all the links to these resources. But the first one I want to walk through is just the CDC COVID data tracker. This is a great resource. You know, the CDC, I think, struggled at first to build a data infrastructure, but they really have some good resources to walk through. And if you go to kind of the homepage for this COVID data tracker, and thanks, Xana is putting these links in the chat box if you'd like to kind of visit these as we walk through. But the homepage here for the COVID data tracker is looking at by county level of community transmission. And this is a metric that we're going to kind of talk through with you today on how you calculate this, as well as how you can use this COVID transmission level to kind of assess your transmission risk in a particular county. So you can click on a county and really zero in on, so we've clicked on Park County here, and it can give you a snapshot of what's going on over the past 7 days for Park County, Montana. So 92 cases, it gives you the case rate per 100,000 people, test positivity, deaths. It's a good resource. You know, some counties do have this resource, these types of dashboard for themselves, but if you live in a smaller county, you might have less information like this coming from your county health department. So the CDC is a great website to look through these resources. The next one you might be a little bit more familiar with is the state of Montana COVID dashboard. So on the landing page, you can look at this tab in the upper upper left-hand corner. You land on the COVID vaccine information, so you can see the total number of doses administered, and click on different counties to see number of doses, and then rate of vaccines that are administered, number of people fully vaccinated. So a great resource on vaccines throughout the state by county. And then on the next tab, you can look at the case numbers. And again, it's just a good comparison. You can compare case count data and case rates across different counties throughout the state. And you also see the epi curve for the state of Montana, just kind of a great landing page for just looking at Montana specific information. It gives you a little bit different info than what the CDC website does. All right, and lastly, I'm going to point you towards a University of Montana dashboard that we've kind of developed throughout the pandemic. And again, this link is included in the chat right now if you want to visit this, but it gives you just a little bit of information compared to what's available on these other resources. So here you can just hover over and get case counts and case rates for different counties. You can look at daily, 7-day average, and then 14-day average case numbers. And we also have information on active cases, not just new cases, and then cumulative total cases over the course of the pandemic for each county. Montana-wide hospitalizations by age group, and finally just some other informative graphs that show things like hospitalizations, deaths, and 7-day average new cases. Just a little bit of information. Lastly, on this website, there are different tabs across the top here. Some of these tabs will show some predictive models that we've tried to develop for the state of Montana specifically, as well as this infection growth rate tab, which shows the current effective R values. So those RT values for the state of Montana using the Montana specific data and serial intervals that I mentioned a minute ago. So you can hover over and get the current RT value for Montana. This is updated every week on Monday. And we're currently at 0.63. So RT is much less than 1. Things are trending down and we're looking pretty good at the moment in Montana. So Xana is going to walk through some of these resources with you and just kind of discuss how these calculations are made and walk through some more examples. But we wanted to give you some resources to kind of take home if you haven't seen some of these as well. So.
Awesome. Well, it's good to see those live. I have a bunch of screenshots from some of those resources. And so all of the data we're about to run through as examples all come from one of those 3 websites that we just looked at. It just will be a static picture instead of looking at it live. At the end of today, we are going to set aside some time for you to go pick a location of your choice to go practice with some of this data. So we're going to be doing a lot of practice, getting a lot of familiarity with some of these data sources. So our goal is for you to know exactly what to do when you're looking at some of these data sources. So I just picked a county as an example for us to run through. Cascade County is the county that we're going to talk about in some of the examples today. So we're going to start with the DPHHS dashboard, and the portion that we're looking at, you can find county level data kind of on the side here of the dashboard, or you can click into the county itself and find some information in a little tooltip that pops up. So we're going to pull out some information from Cascade County, looking at the total number of cases, the number of new cases, and the number of active cases, just from the left side of the dashboard here. So in Cascade County, when this was about a week ago that I took this screenshot, we see that from the dashboard, there's 24,053 total cases, 188 new cases, and 331 active cases. So in this case, we're still looking at just count data. We're just counting the total number of cases. We're counting cases over a specific time period. When we're talking about 188 new cases, this count data would match incidence, because that tells us how quickly the bathtub is filling up, how many new cases there were on a single given day. The 331 active cases would be our prevalence. So this tells us what the current water level is, how many cases are currently active on the day that this screenshot was taken. For the 24,053, that's the total or cumulative cases. And that's the total number of cases since the beginning of the pandemic. Keep in mind that there are likely repeat individuals, an individual who has a COVID case more than once. So again, just pulling out some count data from that DPHHS dashboard. We're gonna hop over to the UM dashboard and look at some additional information around count data still. And the numbers are going to agree with each other. So I looked at this data on the same day, and if we remember from the DPHHS dashboard, it said there were 188 new cases. And when I came over to the UM dashboard, it also says there were 188 new cases. And so we're looking at the tab that shows today, what the situation is like just for today. And that's showing the 188 new cases. Now, oftentimes, particularly with COVID-19 data, we'll see it reported not just for today, but on a 7-day average. And so if we were to switch over to this second tab here and look at the 7-day average, we're still looking at a count. It's still just the number of new cases. But instead of just looking at today, we're looking at what was the average over the previous 7 days. And for Cascade County, that was 90.6. And so to understand kind of where this 90.6 is coming from, we can look at what the data showed us for the previous week. So remember, the 188 is what we saw on the dashboard for the day that we looked. And then this data for the previous 6 days is not necessarily shown on the dashboard. But if we add up all of the 7-day total here, so if we add up the 188 plus 154 plus 4 plus 3, add it all up, divide by 7, that's how we get the 90.6. So it's still just a count, but it's a count that's been averaged over 7 days. And the benefit of looking at a 7-day average versus just 1 day is that averaging over 7 days smooths out any dips from weekend or holiday reporting. So this is data from February 23rd and the 6 days prior to that. And February 21st was actually a holiday. So we can see that there were some dips in the reporting for the weekend and the holidays that may not be totally accurate just because of the day of the week that they landed on. And so averaging over 7 days gives us a better picture of what a typical day's count might be, not accounting for the weekends. So again, count data, it's useful to track over time. If I'm just looking at Cascades County data over time, just looking at the count might be super meaningful to me. But if I want to compare that count number to a different location, or if I want to start looking at kind of different information by age group, we're going to have to look more into those rates instead. So again, why do we use rates when counts are so simple? So using a rate makes a more fair comparison across different size populations. Now, 2 terms that you might come across as we start talking about rates, or as you look at different data that's available, you might hear something that's called a crude rate. And then there's also another term called an adjusted rate. So a crude rate is what we're going to talk a lot about today with COVID data. It's adjusted for the population size only. So in the denominator, we're just accounting for how big the population is. Age is another important factor to consider, and that's because disease and death are often associated with age. So if we're thinking about 2 populations, and if one population is on average older than the other, we would maybe expect there to be higher mortality or higher disease in the older population. And so there's another statistical method we can use called age adjustment that accounts for the fact that not only are population sizes different, but the age distribution within those populations also may be different. And so that's what we sometimes call, for shorthand, an adjusted rate, and that would be an age adjusted rate. We're not really going to get into age adjustment with COVID-19 necessarily, and it's more complicated to actually do age adjustment. Typically, this is just if it has already been calculated for you and you see that there's an age adjustment, know that it's just an extra layer of adjusting for the age distribution to kind of make a fair comparison against 2 different populations. So keeping with some of the numbers that we've looked at before, so at the top, we've got the 7-day average new cases. And again, these are just the counts. So we already kind of looked up how to calculate that Cascade number, the 90.6. Now let's say I want to compare Cascade County's cases to Glacier County, which for the same time frame had 18.4 new cases averaged over the 7 previous days. Now, again, we know that the underlying population is different between these 2 counties. And so it's hard to assess whether COVID-19 what it's like in those two counties without knowing more information. So the measure that we could use here is instead the new case rate per 100,000 in the population. And so what we've done is we said, well, how many cases would Cascade County have if they had 100,000 people in the population? And same for Glacier County. How many cases would Glacier County have if they had 100,000 people in the population? So we've standardized this number, and we find that Cascade County had a case rate of 111 per 100,000, and Glacier County 135. So once we've accounted for that difference in population, we can see that the case rate in Glacier County is actually higher than Cascade County once we've accounted for the difference in population. So if we look again at this same dashboard, so this is this dashboard from the resource, within the same map, you can see both the count of the cases in addition to the rate. But the color of the counties here actually matches the rate. And so if we look at the two that we just calculated, Cascade County and Glacier County, we can see that they're both in the dark blue because they were both pretty high in the 100s. But we're now able to compare all the counties against each other and see that the lighter colors would have a lower case rate per 100,000 and the darker colors have a higher case rate, accounting for the difference in population. So just to walk through a few more examples, this is a map from early on in the pandemic, but I think it's a nice visual. This table here on the right shows us of these 5 states, how many cases they were each reporting. Same situation like with their counties, we know that the population across these states looks different. And so it's hard to compare cases reported to one another when we know that there are more people living in Idaho than live in Montana. There are more people that live in Montana than live in North Dakota. We need to standardize this data and look at it as if all the populations were the same in order to see, what is the burden of COVID-19 among all these states. So if we look at Montana as an example, back when this data was pulled, there was 10,163 cases reported. So that number is going to go into our numerator as the number of cases. And then in order to standardize it, we're going to divide by the population in Montana, so a little over 1 million. And in order to standardize it so that we can talk about per 100,000, we're going to multiply the resulting fraction by 100,000 and get this 950.9. So that's where this number here in the Montana state comes from. So we did the same thing for the 4 other states. We divided by their population and multiplied by that 100,000. And now we can make a more fair comparison. We see that the 950.9 in Montana is still much lower than the 2,068 in Idaho. So the burden of COVID-19 back in September of 2020 was lower in Montana compared to Idaho, accounting for their difference in population. One other source of kind of a benefit for standardizing is looking at testing positivity. And so this chart was from the end of 2021, and the gray line is what's looking at a positivity number. So we're looking at how many tests were given as the denominator and how many tests were positive, and that's our numerator. And when we divide those two numbers, we get a percentage, and right before the end of the year, it was just under 10% of all tests that were given were coming back as positive. Now, the positivity rate is something that we're gonna see that's in the CDC tracker as well. Another example of how over time the number of tests is always changing. And so standardizing this to a percentage instead of just looking at the total number of positive tests gives us a better sense for kind of controlling for how many tests are given at a certain point in time. This was particularly helpful early on in the pandemic when tests were very limited. And then as we started ramping up and we had more tests available, we needed some sort of percentage in order to be able to compare across time since our testing availability was changing. So this chart that we're looking at here is just for the whole state, and it was from a static report. You can look at this testing information from the CDC website that we shared. It'll show you this information by county. So just to walk through how this percentage is being calculated, if we look at the tool from the CDC, they just are reporting the percent positivity, and this is averaged over the last 7 days. For Cascade County at this time period, it was 28%. And this same percentage here is what's being mapped in this chart just to the right. We're looking at how the percent is changing over time. So just to help understand, where does this 28% come from? The calculation is that on average over the last 7 days, there was 143 positive tests given. Or sorry, there was 143 positive tests that came back. There were 512 tests performed. And so we divide 143 by 512 to get 28%. Just quickly to walk through an example of the age adjustment that we were talking about earlier, and why it might be important to do age adjustment. This is not a COVID example, but just to kind of give you a sense of where this might come into play. If we look at cancer mortality between Montana and Florida, the underlying age distribution of these two populations is not the same. So on average, the Florida population is slightly older than Montana. We can see that with the median age. In Florida, the median age is 42, where in Montana, the median age is 40. We know that the number of cancer deaths is going to be different because Florida has a much larger population than Montana. And if we just control for the population, we get a crude rate of 198.8 in Montana versus 218.6 in Florida. So it looks like there are more cancer deaths in Florida than there are in Montana if we just compare by population. But if we also account for the fact that the Florida population is on average older than the Montana population, and we get an age adjusted rate down here at the bottom, we see that the mortality rate for cancer is actually the same among these two states. So just an example of why age adjustment is important. We don't see a lot of age adjustment within some of the COVID data. That there's so many different factors playing into some of the interventions, and age adjustment is just not something that has been kind of reported in a lot of the resources that we're sharing, but just an example of where you might see this age adjustment come up. So we're going to do a quick knowledge check on this idea of incidence versus incidence rate. And so we're going to use Bighorn County as an example, and we're going to talk about the total new cases, so the count of new cases and the rate per 100,000 as a 7-day average. So the incidence, just looking at the count, Bighorn County had 9 cases. If we look at the incidence rate, they had 67 per 100,000. So the question here is, how can the incidence rate be higher than incidence? So think about this for a minute. You can put your thoughts in the chat and we'll kind of talk through it after just about a minute here. All right, so walking through kind of thought process on why incidence rate would be higher than incidence. And population is definitely the reason for it. I see that answer in the chat here. So incidence rate is standardized to a population of 100,000. And in Bighorn County, their population is only about 13,000. So what our incidence rate is doing is saying, well, how many cases would there have been in Bighorn County if instead of 13,000 people, 100,000 people lived there? And so yeah, because their population is less than that 100,000, in order to calculate that rate, the rate's going to go up as if their population was actually 100,000. Great, so just a couple more examples of different data on some of these resources that we shared. Vaccine data, I know Ethan kind of walked through this on the DPHHS dashboard. I'm just going to pull out a few pieces that might be useful in your work. This dashboard does include county level data for those who are vaccinated. Just looking at some of these kind of statewide level data, we've got the total doses administered, total number of Montanans that are fully immunized, and then the percentage of eligible population that's fully vaccinated. So I want to talk a little bit about this 54% and where that number comes from. So it is calculated based on this 55,000. So we take the total number that's fully immunized, and we divide that by the eligible population, which is not necessarily reported here on this dashboard, but it's 1,027,000 or so. So if we take 555,000 divided by about 1 million, we find that there's 54% of those eligible that are currently fully immunized. So that's just kind of how this 54% is calculated. Again, you don't have to do that calculation, that's already done for you on the dashboard, but just to kind of understand where some of these numbers are coming from. Now, the CDC dashboard does also have some information on vaccinations as well. So it's got a similar percentage of the total population that's fully vaccinated. What's different about the CDC data is that it also breaks it down by different age groups. And so what I have highlighted here is just the percentage of the total population. And then we can see that as we kind of go down this table, it's breaking it down by those who are older than 5 years old. We've got 12 years or older, 18 years or older, and then I've highlighted down here at the bottom those who are 65 years or older. So this is a useful tool if you're thinking about, maybe you're concerned about your older adult population and want to know what the vaccination status is. The CDC resource can give you some insight on, maybe what that specific population's vaccination rate is. And so here we have 83% for population 65 and older, which is higher than the total population of 54%. So when thinking about some of this vaccine data, we're going to talk a little bit tomorrow about herd immunity and some concepts like that. But if you want kind of a way to think about, well, we're looking at Cascade County data, it's at 54%, is that good, is it bad? How do I know what to compare this to? You can always compare it to neighboring counties or other locations that might be similar to your own community, or you can compare it to the state average as well. So in this case, if I was in Cascade County and I saw that, 50, just slightly less than 54% were fully vaccinated compared to Montana at 59%, I'm seeing that I'm performing maybe lower than the state average. Just kind of gives me a benchmark to help compare to. So the last kind of tool that I want to talk through before we take a short break is this level of community transmission, which is a framework from the CDC. And what they're doing is they're taking two pieces of data as input, and then they're classifying the transmission on this scale of low, moderate, substantial, and high. Now, the two pieces of input that go into this framework, we've already looked at the data, gone through a lot of the examples. So the first piece is the total new cases per 100,000 averaged over the last 7 days. So we found that number, it's on the DPHHS dashboard, it's also on the UM dashboard, that was our 111.34. So that's the first number that we needed to go find, was our new cases per 100,000. The second data point that goes into this framework is the percentage of positive tests. So we also found that on the CDC website. We found that that was 28% in terms of how many of the tests were coming back positive. So now once we have these two data points, we then look to see where they fit on this chart. So a new case rate of 111 puts Cascade County on the high box here, and testing positivity of 28% also puts them in the high transmission. So again, this was a week ago. This might not be accurate today. They might not be in the high transmission level still. But just to help understand, when you look at the map on the CDC website, it's going to have your county already colored into one of these levels. So you don't necessarily have to look up the data and find where you are in the boxes, but just to start thinking about what does it actually mean to be in the high transmission level, and kind of breaking it down to these two data points that we've already looked at and kind of talked through to kind of understand where some of these different tools are coming from. So with that wraps up some of our initial data kind of framework and practicing some of these examples. We wanted to take a 10-minute break before we start back up. So it looks like it is about 3:05 now. We can come back at about 3:15.
Sounds good. Thanks, Anna.
All right, we're at 3:15 now, so we've got about 45 minutes left today. Hopefully y'all were able to take a quick break and stand up a little bit. So Zana just walked us through some data resources and examples on calculations, and I'm going to spend the rest of the next 30 to 40 minutes on talking about epidemiological study designs and bias. Because these are very important concepts in epidemiology, and particularly in the context of COVID-19. So, I mean, you might think that I'm not designing studies, I'm not conducting studies, so why do I need to know about study designs? But it's so important to help us really interpret epidemiological evidence and scientific evidence in general, because there's a lot of misinformation out there today. Particularly when COVID hit, we were just flooded with new studies, and some of them aren't of the highest quality. So we have to know about different study designs and different forms of bias that we can find in studies, so that we can really be more equipped to interpret the evidence and know what information we can trust and which types of studies and what information we should be skeptical of. So this discussion kind of starts with this concept of correlation versus causation. Correlation is easy to observe. It's just a statistical tool that describes two or more variables and the relationship between those variables. So if one goes up, the other one goes up, they're positively correlated. One goes up, the other goes down, they're negatively correlated. However, correlation says nothing about causation. And when we talk about causation, we're talking about cause and effect, that one event led to the other. And that's what we need to know and get better at kind of diagnosing. And when we're looking at scientific evidence with all of the information available today. So going through some examples here, correlation can seem very obvious at first. For many people, when they see two things that are correlated, they really equate that correlation to cause and effect, but that's almost never the case, because life is complex, environments are complex, and things are almost really never as simple as they seem. So seeing two things that are correlated and claiming that one caused the other is kind of synonymous to claiming that an anecdote is scientific evidence. So an example I like is that, you might think that eating bacon every day is healthy because your father did it and he lived till he was in his 90s. But that's not scientific evidence. That's an anecdote. It does not mean that eating bacon every day is healthy. Your father just had good genes. That's an anecdote. So similarly, when two things are correlated, it doesn't mean that they're cause and effect. So take this example in the figure here. We see that as sales of ice cream goes up, forest fires goes up. It does not mean in this figure that forest fires cause the sales of ice cream to go up. They just happen to be related. And what's going on here is that these things both occur during hotter months. There's this third variable that's confounding the relationship. So this is not a causal relationship between ice cream and forest fires, but it's occurring because of the temperature when both of these events occur. A little more outrageous correlation here is number of people who drowned by falling into a pool is correlated with films Nicolas Cage appeared in during the early 2000s. Now this is a fairly strong correlation. You can see that as drownings go up and down, Nicolas Cage films go up and down, but this does not mean that these are related. This is happening by chance. And an example like this might seem silly, but this is exactly what happens even in examples that do not seem as silly and things that could be related. They're simply related because they're correlated, but not because one is causing the other. So that's why we get into scientific studies and study designs, so that we can kind of help diagnose what is actually going on. Are these things actually related, or is it just some chance correlation? One is going up with the other one. So it's always good to be skeptical about outrageous claims like this. If it seems too good to be true, it most likely is. Things are never that simple. And going back to this previous link, I guess, when you get these slides, there are some actually really hilarious correlations in this website if you want to go through and look at that. But we're going to move on in the interest of time. Study designs then. We're going to kind of work through this flow chart and talk through all these different types of study designs. So we start with the top question here of, did a researcher assign exposures in the study design? So that's our first question. It helps us distinguish whether this is an experimental or an observational study. So did the researcher assign a treatment or exposure? If they did, it's considered an experiment. And this is what all of our drug trials, all of our vaccine trials are. You're assigning an exposure or a treatment within the context of the study. So it's an experiment. If it's not an assigned exposure, then it's an observational study. And they both have their own really strengths and weaknesses in these different types of studies. So we're going to walk through those. So starting with experimental study designs. When a researcher assigns an exposure, it's typically done randomly. And we're going to talk through why that is so important and why we use randomized controlled trials. And these are the gold standard of research. So, but this is what this looks like. You start with a study population, and they're typically volunteers who volunteer to participate in a study. And then they're randomly assigned to two groups. So if you want to look at like a COVID treatment, test the efficacy of a new COVID drug or something like that, you would recruit the study population once they have COVID. And then one group would be randomly assigned to get that new treatment. The other group would be randomly assigned to get the standard of care before that treatment. And then you would look among those two groups to see who improved and who did not, and then compare and make associations based on within the context of this trial. So within the context of a randomized trial, we're looking at efficacy. And quick side note, efficacy and effectiveness are often used interchangeably and incorrectly. So efficacy is when we're looking in the context of a randomized or a controlled setting, like a randomized trial. So this is what's going on under ideal scenarios, under controlled circumstances. So how well do vaccines work if everyone gets both doses on time exactly as prescribed? This is the efficacy of a vaccine. Effectiveness is more talking about real world scenarios. So how well do vaccines work when some people may have delayed or missed doses, some people may not get them at all? How effective are they in a population in a real world scenario? So that's effectiveness. Just a little side note. So when we're talking about these trials, we're actually looking at efficacy. All right, so experimental studies. A randomized controlled trial is the gold standard of scientific research. So why is that? So the short answer is we're going to walk through examples, but the randomization process helps minimize bias in the research study. So when you recruit participants into a study, they're all going to have differences that could impact how the treatment works. So things like age, race, sex, so socio-demographic factors, even genetics, they can all impact how the treatment works. These potential factors are called confounders. And so we're going to look at examples of how these differences in study participants could impact the results and why we randomized. So confounding then, this is an important form of bias that we're going to talk about a couple times, but it pops up a lot in research studies, and it's important to know what this is and understand how this works. So a confounder is a distortion of the association. It's a variable that distorts the association between exposure and outcome. And that's this third variable that oftentimes is unknown. So if you're looking at a new medical treatment for COVID-19, so you have one group that gets the treatment and one group that gets the placebo, but you don't randomly assign who goes into which group. So the first 50 people who sign up get the new treatment, and the next 50 people get the placebo. So then when you calculate the results, you find that the treatment improved health outcomes related to COVID. So this is what we're observing here. We're seeing this, what we think is a causal association in letter A here, where the new COVID treatment improved health outcomes. But what we didn't know, though, was that the first 50 people who signed up and got the treatment were actually younger on average than the second 50 people who got the placebo. So it wasn't really the treatment that improved health outcomes, but it was the fact that the participants in the treatment group were younger that led them to have better health outcomes. So you're thinking that this treatment worked, but it was actually confounded by this variable of age, is what we see in column B here. So it's the actually age that led to the better health results in the participants, not the treatment. So this is why confounding is so important. Sometimes we know the age and we can help adjust for this. Other times we have no idea this is going on, and this type of bias will creep into these research studies. So the problem is, in the study, you didn't randomize who got which treatment, and the two groups had different ages. So when you randomly assign who gets which treatment, like in a randomized trial, this process helps ensure that the two groups here, the new treatment and the current treatment groups, that they will have similar age, similar sex, similar race, similar socioeconomic status. Any potential confounder will be equally distributed across these two groups because they were assigned randomly. So this is why, this is one of the biggest reasons why randomized trials like this are the gold standard of research, because confounding is such a big issue in scientific research, and randomization helps control for that. So hopefully that makes sense. Another good example is, I think this has been an actual study in the past, that researchers looked at increased coffee drinking, and they found that it was associated with risk of pancreatic cancer. And alarm bells start going off because you think everybody drinks coffee and now everybody's going to get pancreatic cancer. But what actually was going on, what they found was that if you drink more coffee, you are also more likely to smoke. And it wasn't the coffee that was causing the pancreatic cancer, but the increase in smoking among heavier coffee drinkers. So it was the smoking that was causing the cancer. Again, this is just another example of confounding and how important of a factor this is in many observational studies, and why we randomize in experimental studies whenever possible. In the interest of time, I'm not going to pop up these examples, but when you have these slides, I just included some examples of each of these study designs with some COVID relevant study examples. Another kind of side note on randomized trials is that they're not just for a clinical setting. You know, I do research in air pollution, and I've done randomized trials in field settings with cook stove interventions in Honduras. That's where these photos were taken, looking at random assignment of newer cook stoves to see if they improve air pollution and health. You can also do this in other settings, and to see if diet, education, or exercise routines randomly assigned, if they improve health outcomes. So very important studies. And we're left with this question of, well, why don't we always just do randomized trials? Why is there anything else? A couple of answers to that. First, randomized trials are very expensive and time consuming to conduct. It's hard to conduct studies with thousands of participants, which is exactly what we did for the COVID vaccine trials. They had tens of thousands of participants. They were great trials, but we can't do that for every single research study. You also can't always randomly assign treatments for ethical reasons. If we want to study the effect of environmental pollutants like radiation or heavy metals or things like that, we ethically cannot assign those exposures to one group and not another, or anybody for that matter. We cannot knowingly expose people to those types of things that are harmful. So a randomized trial does not work for all different types of studies and all different research questions. So when we cannot do that, then we're reliant on observational studies. So in contrast to experimental studies, in observational studies, we're not assigning a treatment or exposure. We're just observing participants over time, potentially with or without an exposure of interest, to see if they then develop the outcome that we're interested in. So In this flow chart, then we're moving over to the right side. We're going to talk about observational studies. And the first question then is there a comparison group? So if there is not a comparison group, then we're talking about a case study or a descriptive study. And this is the most basic type of observational study. So there's no comparison group. We're simply describing a population. And these studies are simple and they're pretty easy to conduct. And we're really, they were common, particularly early on in COVID. We wanted to describe what's going on in the pandemic, who's getting, who's more at risk by saying among different subgroups of the population who has higher rates. And these are all descriptive type studies, but there's no comparison group. So we can't really make any causal claims from these types of basic studies. They're good for generating hypotheses and future research questions. So then we're going to move over to, on the left side of this split, is there a comparison group? If there is, then these are considered analytical studies. And then 3 different types of analytical studies kind of depend on the temporal direction which the study is conducted. So we're going to start with the simplest kind, a cross-sectional study. All right, so cross-sectional studies are really just a snapshot in time. You're looking at a population at one point in time, and you're looking at different groups in that population and classifying their exposure and their disease status. So you can really, you're taking this population and you're dividing them up into groups. So who was exposed, who was not exposed, who was diseased, and who was not diseased. And then you can kind of base associations off of these comparison groups and get an idea of did the exposure that you're interested in impact the health outcomes that you're interested in. So there is a comparison group in cross-sectional studies, so you can calculate associations. The strengths of these is that they're easy and they're pretty quick to conduct. They're cheaper. You're really just, a lot of this will be data that's already collected, and it's just one point in time. So you're not having to follow participants over time. That's very time consuming and expensive. So you can do large populations with cross-sectional studies. The problem is that they are more subject to bias than other types of studies. Confounding is a big problem that we talked about. That pops up in cross-sectional studies a lot. We also have this temporality issue. It's kind of a chicken or the egg when we're studying an exposure and an outcome, but we're only looking at a snapshot in time. We don't really know which one came first. So we can't really make claims about causality because we don't really know if the exposure we're studying came before the outcome. So cross-sectional studies, they have an important place in research. They're easier to conduct and they give us a lot of information, but we can't really make causal claims just from a cross-sectional study alone. Now, the next one is going to be a case control study. So with a case control study, we're kind of starting at a different point. It's still kind of a snapshot in time, but what we're doing is we're starting with a group of people who have a disease that we're interested in studying. So we're recruiting, you often do this from a hospital setting or something. So you recruit participants who have an outcome that you're interested in studying, and these are your cases. Then you recruit another group of participants who are similar to the cases, but who do not have the disease. And then you kind of retrospectively, you're looking back in time to assess their exposure status. Do they have an exposure that you're interested in? So I'll do this with air pollution research, right? I'll look, say we want to recruit cancer patients from a hospital, and then we'll look back in time and try to assess what their previous air pollution exposure was to see if there were differences in air pollution exposure among the cases and controls in the study. So we're kind of looking back in time, and one good thing about case control studies is that, again, they're relatively cheap and quick to conduct because we're not following participants through time. We're recruiting them based on their disease status and then looking back in time to see what their exposure status was. And The problem with this is that we're very dependent on historical records to look at that exposure status. So if we want to study air pollution, we had to have good sources of historical air pollution where these participants used to live. Similarly, if we're looking at other exposures like lead and childhood outcomes, looking at neurologic outcomes in childhood, if we want to look back, we have to know how to quantify their lead exposure previously. So case control studies can be very good if you have a good source of that exposure information, but if you don't, they can be very difficult to conduct. All right, and then finally, cohort study is another kind of analytical observational study. Now with a cohort study, these are going to be the most time consuming to conduct and the most expensive, but they're the best quality observational study because we're actually following participants through time. So we're starting with a group of participants who do not have the disease we're interested in studying. And we have two groups, an exposed group and a non-exposed group. And then we follow each group through time and see who in each group develops a disease that we're interested in learning about. So with cohort studies like this, we're not worried about temporal issues, the chicken or the egg thing, because we know for a fact that when we started, all the participants did not have the disease. So we know that the exposure came before the outcome that we're interested in studying. The problem with cohort studies is that they take a very long time to conduct. Particularly if you're looking at outcomes that are rare, like cancer, and you're recruiting a group and waiting until they develop disease over time, and this can take a long time, which takes a lot of funding and money to develop these types of studies. They are the best study to conduct to look at a causal relationship outside of maybe a randomized controlled trial. But they're very time consuming, and there are other factors, and so there's really no perfect study. They're not ideal if you have very rare outcomes and you're waiting for people to develop these diseases, but they do account for a lot of other forms of bias and temporal issues that you see in other studies. All right, lastly, I want to just mention ecological studies. So most of, if not all the studies we talked about previously, we're talking about individual level data. So we have data points for each individual who is enrolled in our study. With ecologic studies, we have aggregated data at, say, a county or census tract level. So we actually don't know individual level data, but it's all aggregated. So we would be comparing numbers across things like counties or states or different geographic areas. The good thing about ecologic studies is that they're pretty easy to conduct because we often have this type of aggregated data that's collected at the county or the state level, but they are more subject to bias because without having that individual level data, we can't account for some of those individual level differences. We just don't have enough information to know about bias, and these often result in misleading associations and outcomes. So ecologic studies are kind of like cross-sectional studies. They're easier to conduct, they're relatively fast, and they're good kind of hypothesis generating studies that can lead to bigger, better studies down the road. So I want to pull up this figure here, and this kind of helps visualize everything we've talked about and how good then are these different types of studies at showing causality, cause and effect. So we go from top to bottom, least effective to most effective, where the very basic case studies and ecological studies and cross-sectional, these are the least effective at showing causality. And then you get gradually progressively better, where at the bottom you see the clinical trials. A randomized clinical trial is going to be the gold standard of research. And so refer back to this figure if you're trying to go through research and kind of weigh the pros and cons and judge kind of the strength of research. This is a good kind of figure to refer back to and keep in the back of your mind. Beyond individual studies, we're just going to touch on this, but are systematic reviews and meta-analyses. So you'll hear these terms. This is when we're combining multiple studies. Like a literature review is the most broad thing you can do. So it's looking at all the available studies on a specific subject. So it's fairly broad. And then if you want to get a little more refined, you can do a systematic review. And these studies have specific criteria. They're looking at a specific question for a systematic review. And then even more narrow is a meta-analysis, where you're taking information from a systematic review and you're pooling data together from multiple studies to do an analysis on all those studies together. So early on in research questions, you only have maybe 1 or 2 studies and you can't do these types of reviews. But when you've done enough studies and you can combine the results of those studies and really assess the whole body of literature, then you would do a systematic review, a meta-analysis. And when you pool these results together, this can really lead to the most trustworthy report on questions in scientific and epidemiologic research. So look out for particularly a well-done meta-analysis is just going to give you the best information on true causal associations in epidemiology. All right, so kind of transitioning then from the study designs into what are some more types of bias and things that can go wrong in studies and that help us further interpret scientific evidence. So we're going to talk a little bit, just a few more minutes about reliability, validity, and bias in epidemiology. So reliability is the easy one. So reliability is synonymous to precision. It typically increases as sample size increases. So the more people you have in your study, the more people, the more reliable those results are going to be. If you have 100 people in your study, it's going to be far less reliable than if you have 10,000. Again, I mentioned the COVID vaccine trials had tens of thousands of participants. So those were highly reliable, precise studies. Now, validity is when we're talking more about accuracy, and this is where systematic error and bias can creep into your study. So this is, I think, gives a good representation visually of what reliability and validity mean. So our goal here is over on the right side, where we have a tight cluster of our points on the target, where they're tight clusters, so they're reliable and precise. And then they're also really centered over the bullseye. So we hit the bullseye, we're very accurate. And so that's where validity comes in. Many research studies, they're kind of all over the place as far as the reliability and validity. If they're not a very tight cluster, if they aren't very precise, you had a small sample size of participants, there's going to be a tight cluster and a wide cluster of results, and you're not going to have very reliable results. Kind of like these middle 2 points here. Similarly, if there's bias in your study, your results are not going to be valid or accurate. And that's represented particularly by this one on the left. These results are precise, but they're not valid. You missed the bullseye. So what we're looking at when we're talking about bias is there bias in your study, or did you hit the bullseye and did you conduct a sound study that has minimal bias? So our goal then is to have reliable, valid results that hit the bullseye. So when we're talking about this validity and the accuracy in our studies, then we're talking about systematic error. And so there are 2 types of validity. External validity is fairly simple. It's how well does your study source population represent the target population? So how generalizable are your results? I won't get into this one too much, but say your source population for your study is hospitalized patients, but your target population is all individuals with COVID-19. So your source population might not be very representative of your target population because hospitalized patients are typically more sick than just anyone who has COVID. So this would be an example of limited generalizability. So just keep that in the back of your mind. But what we're really going to talk about for these last couple minutes then is going to be these 3 types of bias and validity. So selection bias, information bias, and then we've already talked some about confounding. Right, so selection bias, this is a systematic error that occurs as a result of it's pretty self-explanatory, as a result of the way that study participants were selected into your study. All right, so for example, say you have some study results. This was an actual study. So among individuals with a documented COVID-19 test, those with diphenhydramine or Benadryl documented on their medication list were more likely to test negative for COVID-19. So does Benadryl then protect against COVID-19 infection? Because that's what it looked like in the study. But what we find here is that there's a potential selection bias because the allergy symptoms were related to the use of Benadryl. And then allergy symptoms also overlap with COVID-19 symptoms. So what's going on here? The study results made it seem like Benadryl is protective against COVID-19 infection, but really these are biased results due to the type of participants selected into the study. The participants in the study, they were more likely to get tested and more likely to test negative, not because of the Benadryl, but simply because they had allergy symptoms that mimicked COVID-19. So this is a selection bias, and it's causing you to report inaccurate results and miss that bullseye. Hopefully that example makes sense, but this is a huge point to remember, not only for Benadryl and COVID, but for any other claims you hear like this about certain medications or remedies that people claim that will prevent COVID-19. Because unless you have strong scientific evidence from things like randomized trials to back up those claims, there's a high likelihood that they're just too good to be true, and that results backing up these claims are impacted by things just like this, a selection bias. Just like we saw here with Benadryl. So again, it's a good reminder to always be skeptical of some of these outrageous claims. Sometimes they can be harmless. Taking something like Benadryl is probably not going to hurt you, even if it doesn't prevent COVID. But taking other certain medications that are not tested and not proven against randomized and using randomized trials can be harmful. So they can potentially do way more harm than good. So this just highlights, I think, a great reason why we need quality research, randomized trials to find safe and effective treatments. We need to rely on the science and not just potentially biased evidence, not just any study. Information bias is another example of bias that can creep into studies. So this is systematic error based on the way you classify your exposure, your disease in your study. So disease participants could be misclassified as non-disease, and exposed participants could be misclassified as non-exposed. So a couple of examples. If you have false negatives from a COVID-19 test, this means that cases of COVID-19 are misclassified as non-cases. This will lead to biased results, and you're missing that bullseye. I study air pollution, like I said, so if I use someone's old residence, address of residence to calculate their previous air pollution exposure, I might be calculating an accurate measurement of air pollution, but if they no longer live there, then I'm misclassifying their actual exposure and I'm missing the bullseye. This would lead to a bias in the study. So those are types of information bias that can come into studies. And then we've kind of harped on confounding and how important that is and why we do randomized trials to minimize confounding, because there are these third variables that can creep into studies and really cause the associations that we're seeing. So I hope, this was kind of a crash course in study design and bias. But the idea here is to give you an idea of what is important to look for in scientific and epi research, and really just why these types of studies and why trusting the scientific process is so important, because not every study is equal. Some are better than others, and you really have to know to be able to look at the design and potential sources of bias to really decipher what the evidence says. And that's why it's just so difficult in this day and age when there's so much information, we're flooded by it. It's difficult even for experts to really decipher some of this evidence. So just my recommendation is to slow down and really just look at what the evidence says and trust the scientific process. So with that, I do have some examples in here of identifying study designs, but I think I'm just going to give these to you in the slides, and you can feel free to practice on those on your own if you would like, because I know Xana has an example here at the end on just being able to go through and kind of practice finding some data sources if you have a few minutes here. Xana, do you want to kind of take over?
Yeah, so this chart here on the PowerPoint that we're showing is also in the supplemental materials at the very bottom. And so if you want to take some time to kind of go through, pick a county that you're interested in and fill in the information in that blank column, it's all data that we went through today. And if you, want a hint of which resource you should be looking at, the link, a quick link of where to find that is kind of on the right column. So we were going to hang around as folks looked for some of this data. If you have questions, if you have other lingering questions from the presentation today, we can also take those now as well. But if you don't have any questions and you want to get started on this, look to that supplemental material to find this table with the links.
Yeah, feel free to use the chat or just unmute and ask away. We'll do our best to answer questions based on our areas of expertise. So we'll also just say real quickly here that as you're working on this, if you need to kind of log off, do come back tomorrow. Please join us again from 2 to 4 because we're really going to focus specifically on COVID and different prevention strategies and talk about the science behind certain things like masks and vaccines, and then assessing and minimizing risks at individual and community levels. So join us for that tomorrow, and we hope to see you there. Thanks for coming today. And again, we'll hang around for a few more minutes to answer questions if you want.